Good morning. For those of you who don't know, I'm Mark Gabay, Professor of General Practice at the University of Liverpool, and I'm the Director of this NIHR Applied Research Collaboration Northwest Coast. And I'd like to extend a very warm welcome to everybody here this morning, either here in the room with us, and it's great to see so many people going, oh, so that's what you look like in real life, or at home in our hybrid format. And I think we're being quite brave doing a hybrid with this many people online. So there will be glitches, and I entirely blame Darren, because he'll entirely blame me if otherwise. So there will be the occasional glitch, but we do need to be quite disciplined because of people not being in the room and being virtual and worrying about timings. So I will be vigorously shaking at speakers, brightly coloured things. There is one that says "get off." Darren was going to wave that at me, I think. So I also appreciate the fact that due to industrial disputes, it's not been easy to get here today, although in fact the traffic was better than I was expecting. I'll make no comment about why that might be, but that might be why there are fewer people here today than we were expecting. So some house rules. Mobile phones on silent, please. And as I say to the students, if they're not, we'll be able to see if I can toss one onto that top balcony from the floor. There are toilets downstairs, and there are also toilets apparently in the gym, but I do believe they're behind a door. It's not just one of those cloche-mail type effects. There are no fire alarm tests expected today. So if you do hear the alarm, please follow the fire exit signs and leave, it says, in a orderly, not disorderly fashion, where you can be counted outside. So the meeting points are on the street just outside. Those who are wanting to use the Wi-Fi, but why would you? Because you're paying such close attention to what's going on the stage. It's Flory 65 with a capital F. Those of you at home, we do have new software that means we can tell if you're doing emails at the same time as attending this, and you will be getting a letter. We've produced an easy guide for you to show you how today is working, which I hope you have looked at so you know where you are and when you're supposed to be, but that's also my job, and I will be very boring and saying we are now going to here and go to there, but no life jackets will be required. It will be quite clear to see. So please keep an eye on where your meetings are supposed to be. As I say, it's either here or downstairs. And in the afternoon, the workshops will move to you. You stay where you are. We will ask people who want to ask a question from the floor to raise their hand, and a mic will come to you. And online, we're doing it with both raising a hand virtually or in the chat, and then the team over there will let us know that someone's wanting to ask a question. And we are using panels today. So I'd like to welcome two panelists here today. One of them is still coming, Professor Caroline Watkins and Dr. Clarissa Giebel, and they'll be our panel this morning. Today's theme is social care research. You may note that it's now called NIHR is now the National Institute for Health and Social Care Research, or they haven't changed the letters. And that's what we want to talk about. We want to talk about the projects we're doing and the potential projects we want to do in the future and how to get involved in that. Can virtual guests please stay on mute unless you're asked to speak by the chair of the session, which will be me, and then I'll give you the 30 seconds to fiddle around trying to find where the unmute button is. It's really important to remind all of our virtual guests to follow the day by clicking the Sessions tab on the left-hand side of the platform menu as the day progresses. And there you can see it has the times and titles of each session that you need to click onto. Otherwise, you might be left behind in a virtual room you don't want to be in, and we wouldn't want that to happen. All our virtual guests will be doing the same things as our in-house guests, but at times, if there's a breakout room, there'll be a separate virtual breakout room. We won't be trying to show you what's happening in the room at the time. You'll be in a virtual audience. And then we will ask for feedback for a nominated spokesperson. We'll still be using flip charts, etc., and pads and Padlets, depending whether you're virtual or in the room. And we have something called the dry erase board, which I'm too young to know what one of those is, but I think it's what used to be called a whiteboard, and we will be using those as well. I'm a great fan of them because I think one of the things hopefully we'll find today is just how lively it is when people are in a room together, sparking off each other in person. So, next slide, please. So I can do that here, can't I? So I'll do that if I've got some control. So we've done lots of things, and I'm not going to go through all these in detail. They're available on our website, and this just shows our progress against our objectives as an ARC, and we've completed all our short-term objectives. We've completed quite a lot of our medium-term objectives as well. And we're well on the way to working on our long-term objectives. And I want to finish with a few things just to say. So today we want to update you about our work. We want to talk about how we can collaborate together on the work we're doing now and the work that we want to do in the future, both in this ARC and more widely across other ARCs. We want to identify how we can disseminate our work and implement it. And Caroline here leads the impact team, which will help us implement well and effectively, and to look at the process of that implementation, which is really important, so we can learn about the process of implementation. And then we pass it on to Innovation Agency, who can then spread that at what they call pace and scale right across the NHS and social care as relevant. As you know, this is all about reducing health inequalities, and that still remains the huge challenge for us nationally, but particularly in the Northwest and the Northwest Coast. Our projects are at different stages, and we need that collaboration from our members and our public involvement, representatives and advisors throughout the projects. The key point about the ARC is it's a collaboration, the clue's in the name. And the ARC is only as effective as its collaborators can make it. So it's really important that you're here and that you're here to find out what we're doing and that you work with us to make this ARC a success. The legacy of the ARC is down to that collaboration and to taking the work of the ARC into the member organisations, building that expertise in research, in implementation, in evaluation, so that the member organisations have that strength and that skills, and they spread it internally. And that's what gives us the legacy and the long-term sustainability. We will be meeting again in person in September for the next ArcFest, and we'll be moving north. So we'll be going to the countryside, and you'll see sheep, because we're going to Kendal. And those of you who can remember that far back, it'll be 3 years in November when we launched the ARC in Blackpool. It'll be hard to live up to that excitement, but we are at the halfway stage. So some of what we're looking at today is towards that. I want to just talk briefly, because I was at a meeting last week, a national meeting of the ARCs, and the NHR were talking, and they were pointing out that today's theme social care research, and they are putting increasing amounts of millions of pounds into sustaining social care and building social care research. And so all of these NIHR grant competitions are increasingly seeking grant applications that are looking at social care as well as healthcare. And it's spreading throughout the programme. And as you know, the ARC doesn't have loads and loads of money. It seems as though it does. We get our investment from successful grant applications to bring that investment from NHR and elsewhere into our work across the region. So let's whet our knowledge appetite with our first session. We have some presentations, some are live and some are coming to us virtually. And I'm going to invite our first speaker.
Hi, everybody. I hope you can hear me. Sorry not to be with you this morning. I needed to change plans because of industrial action. So today I'm going to talk to you about an evaluation that we did, that we were commissioned to do about an integrated care intervention in Liverpool. When we are talking about integrated care, we are talking about bringing together health and social care. This effort has been one of the major characteristics of the decision making in recent years, for several years now, particularly in high-income countries. And the idea is that when people live longer and with more long-term conditions affecting them as they grow older, health and social needs become so closely linked and intertwined that the boundaries between disciplines and organizations become a barrier to what this person needs with its own unique circumstances. And so if we improve coordination and collaboration between organization and disciplines wrapped around the care of a person, this would bring a better experience for patients, for example, avoiding fragmentation, needing to go to several things different times, better outcomes because it may improve identification of needs and that are unique to this individual, and would also be beneficial for the sustainability, the financial sustainability of the services, because prevention is cheaper than taking care of crisis. And there may be some potential savings, for example, in pooling resources. So these changes are happening at the national level. For example, in July, in 2 weeks' time, less than 2 weeks' time, there will be the start of integrated care systems in England. And there are also a number of local interventions that are happening all around the countries. And if you can give me the next slide, please. So these interventions are the intervention that we evaluated in Liverpool is one of the interventions that are more commonly found in England. And it's about the creation of multidisciplinary care teams that in a way shift the load of taking care of some of patient a little bit more away from the GPs and more into the community and in the care of community teams. So community teams are usually district nurses, community matrons, there's medicine management, therapists, health visitors, midwives, school nurses, all these kind of health professionals. So in Liverpool, the integrated care teams was a reorganization of this community team with the creation of a new role, which is called a clinical care coordinator. And all these people were employed by the same NHS organization, and they were commissioned by, together with health commissioners, Liverpool CCG, and social care commissioners. So they were paid by the Liverpool City Council as well as an NHS. So it's an example of pooling resources together. And so what do these teams do? So all people that were thought to be liable benefiting for this kind of care will be referred to the service, and in the service altogether different disciplines, GPs, community, voluntary organization, clinical specialists, and social workers will look at the characteristic of this person and draw up a plan, a personalized plan of care, and there will be a care coordinator that specifically is responsible for drafting this care plan with different disciplines and with the person in question and following it up. So can I have a next slide, please? So how would this kind of approach lead to improvement? It's a shift between being reactive and having too much emphasis on acute care when things have already deteriorated and require urgent attention and crisis management to a more proactive approach that is based on managing a range of conditions better in the community and preventing escalation, preventing things becoming worse than they need to be. And how are people going to do this? So it's about a lot of these professions that I have highlighted that make up the multidisciplinary care teams. They all can refer into the service, and all are asked to actively and purposefully identify people that are at risk of going to a crisis or require acute or more complex interventions. And so, for example, GPs in Liverpool have been asked to use some risk stratification tools, so some score of the risk to require urgent care in the next 12 months, together with clinical judgment to identify people that may need. So the service was open to everybody over the age of 18, but especially in their aims, people that are complex needs, that are elderly, frail, and they have multiple conditions. So because of this emphasis on avoiding burdening the hospitals, a key measure of success in England, as always in the UK, has always been reducing unplanned admissions. However, the literature, it doesn't support that much this emphasis on this particular target or key performance indicator. The literature shows that this intervention are usually associated with higher unplanned admissions when studies that are robust and they use the comparators taken into account. So can I have a next slide, please? And so when we have designed our study, what we decided to do is to take into consideration both the unplanned admissions and also mortality, because it may be that these interventions actually increase lead to longer lives, and in that case having an increase of unplanned admissions is normal. So what is the group of people that we have evaluated? So our group that has been treated, so they went through the intervention, was all people enrolled in Liverpool in multidisciplinary care teams between January 2017 and February 2019. This was January 2017 was the start of the intervention in Liverpool, and we followed them up for 12 months from the beginning of the intervention. And the comparison was with people, so the pool of people that we could compare against was the rest of the population of Liverpool, which is about 390,000 people. Can I have a next slide, please? So we used, to do the study, we used mostly primary care records that had been then linked to hospital records to know the story of use of services. We linked them to mortality records, and also because professionals and GPs were asked to use a risk score, we used also the risk extract, which is a tool which is made up of 37 different variables that may indicate that a person is more at risk of being admitted to hospital. And from these records, we derived a lot of measures that you can find here: age, gender, deprivation risk, the number of long-term conditions, the number of medications that they used, and if at the beginning of the intervention these people were diagnosed with cancer, heart disease, respiratory disease, depression, and dementia, and also their past history of using the services. So we consider these measures because when we wanted to make a comparison, we wanted a set of people that had similar characteristics to these high need, high risk populations that are using the services, the integrated care teams. And so we derived, for each person in the intervention, we derived the 5 people to compare against. So we had a total group of comparators, which was 7,575 people. Can you have a next slide, please? And so we study what we decided to do for the admissions. So the outcome in question is the level of unplanned admissions. We did a study which is called a difference in difference study, in which we compared the change, the difference in outcomes in admissions in the intervention group to the change in admissions in the control group, which was matched. And we followed these 2 groups 12 months before the intervention and 12 months after the intervention. And this kind of study gives an indication of what the effect of the intervention is. If the 2 groups, the comparison and the intervention groups, had similar trends before they started the intervention, so they had also a certain history of seeking services and accessing services. So can I have a next slide, please? So when we did this study, we found out that yes, our comparison group, they had the same, before the intervention, they had the same history and they were well balanced in terms of characteristics. And we found out that the people that were enrolled in multidisciplinary care teams in Liverpool were actually had a slightly higher level of unplanned admissions. So they had about 15 more admissions per 1,000 in a month, if compared to the rest of the population, to the control group. And so, can I have a next slide, please? So this might have been because of increased survival of the people that were accessing multidisciplinary care teams. So we have also had a look at the probability of surviving, and we found that actually there was no particular difference between the likelihood that these people were still alive compared to the control group in the 12 months after the start of the intervention. And so, can I have a next slide, please? And so, where does that leave us? The fact that we haven't really found any particular improvements in these outcomes, in these only 2 outcomes that we consider, it doesn't mean that this intervention is not useful and is not successful. The whole concept about integrated care teams is that it's about the person as a whole, and it may be that caring for a person as a whole may be more expensive, more time consuming, and lead to more admissions because more needs are identified and taken care of. And so there is a large volume of evidence that indicates that actually these particular interventions actually improve quality of life. So taking into consideration qualitative quality of life outcomes may be called for together with this key outcome that is usually taken into consideration, which is the reduction in unplanned admissions. However, it may be that this intervention wasn't particularly successful in the stated aim of reducing unplanned admissions, and this is my take on what we have observed. First of all, this it takes a lot of time. This is a complex change in the way to care for people, so it takes time. And this intervention, we just evaluated at the very beginning, from the first day one that they started rolling out these teams. And actually all evidence points out the fact that this integration needs at least 5 years to become more for people to see changes, and which is actually quite interesting, because all this evaluation and all the funding to install and to implement these interventions is usually only 2 years. So there's probably something to be said about extending funding range and availability. Also, this particular intervention wasn't particularly richly funded. The second thing is that this intervention was designed and to reach the most complex cases, more high-risk cases in Liverpool, and there may have been that these cases were too complex for the capacity of services, and the range of needs was just too wide. So there is a large body of evidence that shows that actually these interventions that take into consideration high-risk groups of people that are not particularly successful in reducing emergency admissions. And I have an asterisk here to point out that we have another study of an intervention in Liverpool, so in the same context, where the offering was more universal for an integrated care team, and they were more successful in achieving their goals. So it may be that it's a case of going wider in the range of people with targets, and also going deeper into just segmenting into different subgroups of complex needs, because there's also evidence that suggests that specializing in particular need groups may be more effective. So, most important thing of all, design interventions with inequality in mind. It was stark to see that for an integrated care intervention that usually they aim a frail and elderly population, there was a very significant cohort of people that were the most deprived, and they were also very young, and they had 80% more unplanned levels of admissions even before this intervention started. They had much higher prevalence of depression, mental health issues, and respiratory problems, so a different disease profile from the rest of the population. When we tried to differentiate into different socioeconomic strata, we found that this intervention didn't have any different effect if we took the higher the highly deprived and the least deprived people. So this intervention was probably not particularly adaptive to consider the needs of the most deprived levels. And the last thing closely related to it, people with that have a high level of deprivation, they also suffer for particularly and sometimes undiagnosed mental health problems, and it's necessary to take this key aspect into account when designing these interventions. And the next slide, please. So this is also to say that this is the work that I have done with my colleagues Jenny Downing, Helen Duckworth, and Ben Barr, and it was funded by Health Foundation and NIHR. And we also had the close collaboration with the Commissioner of this service, with Liverpool CCG and Council, and we were also supported by Mersey Care, which took the administration and the implementation of this intervention from 2018. So we are indebted to them. And on the next slide, please.
Thank you very much. We'll take questions in the panel. So can I please move us on to Clarissa Giebel? Dr. Giebel works in the Health and Care Across the Life course theme, where she's a senior research fellow. Try not to break your leg walking across the stage.
Yeah, well, thank you for having the opportunity to speak here, and it's nice to see everyone face to face again. So I'm going to share a little bit about our Liverpool Dementia and Aging Research Forum, but also some of the social care research within the dementia and aging field that we've been doing over the past 3+ years since the forum has been alive. I hope this is working. Yes, great. So I set up the forum in 2019 because I felt that there wasn't really a big connection between all the different professionals and lived experts with experience as well to date in Liverpool, because it's really important for me to have those academics, kind of like the ARC as well, to have those health and social care professionals, lots of charities, and I see the Brain Charity here is here as well, which is lovely. But also we have a lot of people with lived experiences and with caring experiences, including here today as well, so this is lovely. And it's really trying to generate, just like the ARC, generate research that is meaningful to people with the lived experiences, but particularly also those at the social care front that are facing those difficulties. So we're hosting every 2 months public webinars. I'm sure some of you will have attended them. We host monthly journal clubs, and the Alzheimer's Society is joining them regularly as well, which is lovely. We have regional networking meetings, which are so far remotely, but we're thinking of having them face-to-face again, because, again, it's all about coming together and sharing those ideas and what's going on. And our annual conference, and I'll speak about that in the last slide. So some numbers, because I'm a researcher, so I have to give you some numbers, sorry about that. We have to date around 6 funded research projects, which have been conceptualized, and throughout the projects have been working with people with lived experiences, people with professional experiences outside the academic sector. We have 7 projects that are currently submitted or in preparation from different team members as part of the forum. Quite a number of papers, and you'll see in a few slides as well on all of our publications and all the non-academic outputs as well. We do have people with lived experiences and people with a social care background as well involved, so all equal. We have around 500 people on the mailing list and quite a few registrations on the webinars. And Professor Siobhan Riley has topped the number of registrations for our webinar. Last year we had over 500, which was quite exciting. But we're not our numbers. So it's really about having all the people that are passionate and interested about dementia and changing how care is done together. So that was actually the last face-to-face forum event we had with Dr. Rhys Davies from the Walton Centre. About 3 weeks before lockdown. I'm not going to say whether any COVID was exchanged there, but it was quite a full house, which was nice to see. And a few other pictures from some of our members and some of our conferences. We have Tide represented as well in Mercy Care. We have quite a few videos of Roy, who is living with dementia. He's living with quite a rare type of dementia, and he's been a very active public advisor on our research. Unfortunately, his dementia has deteriorated quite a bit, so he's not really that engaged anymore. But on our ARC YouTube channel, you can see videos of Roy, and I would give them a go. It's really nice to hear from him. And this, I think, captures the public involvement angle of the forum quite nicely as well. So we have here Sarah Butcher, Dr. Sarah Butcher from Mercy Care, and Dr. Jill Pendleton as well. And we hosted this event after one of the forums to really get together all the people with lived experiences, with caring experiences, to understand what do you want to see changed in dementia care? What's your important issues at the moment? That was a really nice get together. So in terms of some of our research, this has kind of been a bit of a background to what the forum is, what we do. As I mentioned, we do primarily social care research on dementia. We don't really look at the cure side of things, we look at the care side of things, and there's always this kind of great division. And we've done a lot of work, particularly during the pandemic, on how the pandemic has impacted on accessing social care and social support services during the pandemic. And this is our kind of Zoom snapshot of all the different organizations and people that were part of this research. And we've also looked particularly at how care homes have been affected during the pandemic. And I'm just highlighting those two studies here because they've been so far kind of key focuses of our forum together and really have pulled together everyone who's part of the forum. And to highlight the care home study here, we've interviewed family members of residents, we've interviewed staff in autumn 2020, and then we followed them up in March 2021. And in between that, obviously, you will be aware there've been increased testing, but also the vaccination rollout. So that has really impacted on how people have been able to access care homes and see their loved ones. Unfortunately, all the carers that we followed up, so family carers, were still unable to see their loved one in the care home despite being vaccinated, despite adhering to regulations, whereas staff was able to obviously go into the care home and in many instances bring in the virus as well. So I'm saying this because this raised the level of emotions in family members, from feeling frustrated, I can't see my loved one, I can't see my husband, I can't see my mum, I really want to see her though, to feeling very angry. And based on these findings, we're now received additional funding from the NIHR to look at the unmet mental health needs of paid and unpaid carers as we slowly move out of the pandemic. So it's really kind of showing the narrative of what we do in the forum, involving people with the lived experiences and trying to build on what we found throughout the pandemic. And just to say, we don't just do research outputs, because they might stay in the ivory tower. So we've done two policy briefings in collaboration with the Liverpool Heseltine Institute, one on social care impacts in the community for dementia, and one on care home practices and mental health and staff support. And also, some of you might know, there's a podcast out there, so if you fancy hearing a bit more than what's just delivered in the forum, there's a lot of episodes out there with international experts, especially from the Netherlands, on how care homes are managed and innovative designs, for example. So again, just another way to engage everyone, and there's lots of carers on the podcast as well. Just to highlight some of our ongoing research, this is a selection. By no means this is all the research. There's more from some of our PhD students here at the ArcFest as well. So I was referring to our NIHR study on unmet mental health needs of carers. We've recruited 25 carers to date, which is fantastic. And Lena has done an amazing job in recruiting them, so shout out to you. We've also started a DECLIN project on the experiences of carers for people with dementia and learning disabilities, recruiting to that. And we are also starting on an interview study on socioeconomic barriers to healthcare usage for people with dementia. It's a PhD project. So just to kind of say, this is roughly the work that we do. And our last slide, because I kind of have to say that we're having our 4th annual conference here at the Flory on the 12th of October. We've received short of 50 abstracts, international abstracts, not just from the UK, which we're currently sifting through, together with carers and support organizations as well, and rating them. And we'll have a full day face-to-face conference, finally again, it won't be remotely. And yeah, we have a keynote speech by Professor Siobhan Riley from Bradford University. And also what I'm quite excited about is we have a live policy debate on stage with the Alzheimer's Society, Liverpool Heseltine Institute and Liverpool City Council to really try and understand, okay, how can we move research into practice? How can we make those implications happening in real life? And that's all from me. Thank you very much.
Thank you. Thank you. So, live applause, that's an unusual sound, even when I was in Old Trafford. So I now want to move on, please, to a pre-recorded session by Victoria Appleton, who works with my colleague here, an impact theme, talking about oral care in care homes.
Liz Bowden's talking.
Is it Liz? Oh, right, sorry, yeah. I have it was Victoria. So.
No.
So why can we concerned about oral care? Well, it can cause psychological and social issues. It can cause significant pain. It's associated with medical issues regarding dental cavities, gum disease, heart disease, cancer, diabetes and pneumonia. It causes a physiological burden and is associated with sarcopenia and cognitive impairment. You have increased comorbidities, increased hospitalisation risk, and it is associated with a higher risk of mortality. So why are we focusing on care homes? Well, residents in care homes have a higher prevalence of multimorbidities and have increased functional limitations, often unable to ask for a toothbrush or to have their mouths cleaned, unable to hold toothbrushes, needing significant help, and they may have visual and perceptual difficulties. Residents' cognitive issues and behavioural difficulties mean they may resist oral health interventions. There may be a lack of oral care equipment, and they may have difficulty accessing dental care services. And oral care in people in care homes is significantly worse in those needing help, owing to carer knowledge and skills, carers' busy workload, and the limited importance that's placed on oral hygiene in relation to other activities they may have. Current NICE guidelines suggest that care home policies on oral health should be in place, providing residents with support to access dental services. Residents should have an oral health assessment and mouth care plans. There must be daily mouth care, suggested twice a day. Care staff must be provided with training on how to deliver mouth care. Must be availability of local health services to residents within the care homes, and there must be availability of oral health promotion services, as well as access to general dental practices and community dental services. Our programme of work to date consists of two phases: an evidence synthesis of oral care from the literature and evidence from clinical practice, interviews from staff involved in the delivery of mouth care to care home residents at staff level, managerial level and commissioner level. During phase 1, we undertook a systematic review to identify the implementation strategies commonly used in oral health interventions for older people in care homes, and we explored the barriers and facilitators to implementation. We searched a number of databases, finding 2,161 papers, but we finally included a total of 15 papers in our review. The results demonstrated that delivering good oral health care was primarily driven by three key factors: health inequalities, care and knowledge and individual characteristics, and organisational priorities. Main barriers included health inequalities of residents, carers' lack of knowledge and skills and confidence, patients' cognitive and behavioural issues and inability to engage with oral care. There was identified a lack of resources to the availability of toothbrushes and toothpaste and denture pots, and care home organisation and the priorities that the care home puts on oral care had an impact on the success of implementation. The facilitators to oral care were engaging with local key stakeholders throughout the planning and delivery stages, ensuring bespoke interventions that took into account the needs of individual homes, and oral care champions who had a key role in the success of implementing training of staff and ensuring access to resources. Phase 2 involved collating evidence from clinical practice. We undertook interviews with staff involved in the delivery of mouth care to care home residents. This stage was funded by QRSPF funding and supported by the National Institute for Health Research Applied Research Collaboration North West Coast. We developed working relationships and networks with our partners between January and March 2021, and during those steering group meetings we co-produced interview topic guides and piloted them to make sure they were fit for practice. We obtained ethical approval, and Public Health England identified potential recruits, identifying the care homes that participated in the Mouth Care Matters training. We conducted the semi-structured interviews via Zoom, and we interviewed staff who received no training, managers who'd received face-to-face training, and commissioners. We transcribed the interviews and analysed the data. During the staff interviews, it became evident that there was a recognition that oral care wasn't as good as it should or could be. Some issues related to residents' inability to comply with the oral care, some comments related to lack of training, or oral care not being considered a priority within the care home. And generally staff just felt they weren't comfortable at cleaning mouths and dentures. The interviews with managers demonstrated that managers were more aware of the process of staff training itself, the regulatory processes and CQC with monitoring. They reported access to toothbrushes and toothpastes were scarce where families failed to provide ongoing resources in this area, whilst one manager reported that she was vigilant in overseeing staff, saying, "I purposefully walk in a room to make sure that the toothbrush is wet, even to the extent where I smell the toothbrush to make sure." So we can see there is a wide variety of care being provided across care homes. Commissioners were more concerned regarding including oral care in nursing home contracts and it being considered as part of quality indicators. They're concerned about accountability and perceived oral care as part of holistic management, ensuring access to healthy diet and drinks and being able to manage nutrition and hydration. This programme of work has allowed us to establish collaborative links with various organisations to better understand local, regional and national challenges. We were able to facilitate knowledge transfer and practice between organisations, and our findings will inform implementation plans for further oral care training. It has enabled us to identify new opportunities for further collaborations. I'd like to thank you for your time today, and I think Victoria is going to take questions. Thank you.
Thank you. So is John from Community Integrated Care here, or anybody here from Community Integrated Care to join the panel, either live or virtually? And Victoria's on virtually as well?
No, Victoria's off sick. That's why you've got...
So you've got, God. Sorry. I have you in person. Apologies, sorry. And Roberta, I meant. Is Roberta on Zoom as well?
Yes, I am.
Great. So we've got 5 minutes in the room and 5 minutes virtually. So we'll start with questions to our speakers in the room, and John can chip in as and when. So I've got 2 hands up. Start at the back with Nevin and then Joe. Please state your name and what you do, please, so that people won't know who you are.
Hello, I'm Nevin Williams. I'm an academic general practitioner and professor in primary care in University of Liverpool. And a question to Roberta, please. I thought your presentation was really interesting. I loved the methods. But I wasn't really surprised that unplanned care increased. I think there's a lot of unmet need that's been identified by the integrated care you've provided. What I was more interested in, I think, is the quality of planned discharge for people when they're in hospital, and whether length of stay can be reduced.
Yes, so it's interesting because one of the channels for referrals to the integrated care teams were at the stage of discharge. And we know that discharge is actually one of the key points of possibly having more problems in the community for these people. So I think it's a good suggestion, and the future evaluations should be taken into consideration. As you say, the length of stay, and also what is the level of integration between services that provide this link to discharge into the community. So would be one of the outcomes that needs to be proposed also at the national level to assess these interventions.
Thanks, Roberta. So, Joe?
Thank you very much. And this is another question for Roberta. I'm Jo Blair. I'm the professional co-lead for HACAL. I really enjoyed your presentation, Roberta, and was a little bit surprised and disappointed by the results. I just wondered, within your data, was it possible to see whether there was any suggestion about the groups that you might focus on? You commented that some of the highly complex patients might not benefit from this this approach. I wondered whether there was any suggestion from your data about which groups might particularly benefit, and whether it might be possible to create a sort of bespoke MDT around those subgroups and look at those separately from the broader population.
Yes, I think if you have a look also at the paper, where is in the appendices, there's also some data about some descriptives about the different groups, different clusters. I think what I found is that there are two different groups of people. One of them more traditional, perhaps targets of these integrated care teams who are elderly and frail, people suffering with dementia and the cardiovascular disease mostly. And then there was a very distinct cluster of really young people, but with high complex needs, socioeconomical needs, so substance abuse, probably undiagnosed mental health problems, but also a high burden of mental health diagnosed and recognized. And I feel these are the two clusters. I think that in our analysis, it seems that for frail and elderly, the intervention was actually quite beneficial. We know from evidence that this cluster of people actually have a high satisfaction and a very good improvement in the experience of care. So I think it's mostly the really complex young and mental health cohort of people.
Thank you. We have time for one more question in the room. And John, I'd love to have your reflections on what you've heard so far as well as a provider, a lead provider. So.
Hello, my name's Bryony Kendall. I'm a GP. I was just, the last presentation on oral care in care homes, I was just wondering if there's any sort of suggestion for a wider focus for commissioning, because oral care at all ages, so adults with learning disabilities, people in more vulnerable things, it's the key, it's still the main cause for hospital admissions for children with neglect. And yet mouth care throughout the life course has never really had a focus within commissioning, and I think there's definitely a place here, especially with the Delegated Commission of Dentistry, but across every health and social care provider, I think there's not enough focus on mouth care in general, and this is an opportunity to at ever level, and it's so associated with deprivation. I think this is an opportunity and yet another way to flag this as an issue.
Caroline?
Yeah, I mean, clearly it is an issue. I mean, we know it's an issue in care homes. We know it's an issue in hospital care. We know it's an issue in the community. So we need some sort of strategic plan, I think, to think about how we could make changes in oral care, across the life course, really.
We have an advantage that Professor Rebecca Harris at Liverpool, who's a professor of public health dentistry in the Institute of Population Health that some of us here work in, is also the Deputy Dental Officer for, I think, England, isn't it? So maybe and she's done quite a lot of work in this area, so maybe one of the things we could think about in the future is getting together a small group to talk about what may be the national commissioning implications for how we can use what we do know from the research in different settings for oral care and how that might affect planning going forward. So it could be an interesting discussion to be had there. Thank you very much. So I'm now going to move on. Are there any questions virtually from the virtual group? Nothing? So can I ask John for your reflections on what you've heard this morning?
Hi everyone, yeah.
And introduce yourself first, sorry.
Hi there. So my name's John Hughes, I'm Director of Partnerships and Communities at Community Integrated Care. So a really large national social care charity with a big presence in the Northwest area. For me, the role that research can play in social care is really, really important. I think one of the things I reflect on when I see the oral care presentation is, you know, when I look at that presentation, personally, as someone who wants to see high standards of care for people, you feel that sense of frustration when you're like, oh, you know, dental care is so instrumental to people's dignity and quality of life and all those different areas. Also, I can see the issues that the social care sector faces. So I'm lucky that I'm part of a big and resilient care provider, but nationally, the care sector's got a 35% turnover of colleagues. We've done some research recently around the social care workforce. And in any other public funded sector, people working in social care would be getting about £7,500 a year extra. So in essence, what you've got is a sector that's got a really high turnover of colleagues, that's not got the means to pay people extra, and is asking an awful lot of people for largely minimum wage or around minimum wage salaries. You know, virtually the majority of the care sector is below the real living wage. I'm lucky that I'm part of an organisation that is a real living wage employer, but most aren't. We've got a capability framework in our charity where we map out the different capabilities that people need for job roles. And, you know, across our charity, there's something like 260 capabilities people need. And that can be things as varied as managing self-harm behaviours all the way through to the oral care issues we saw there. So I think my takeaway from all of this is the role that academic research can play is really, really useful. It's invaluable, in fact. It gives capacity, it gives impact, it gives new thinking. But just being grounded in the realities of what it's like in social care and finding ways to work in a really collaborative and easy and fluid way, and having great conversations with providers to understand their realities. I think when you look at care providers versus NHS organisations, often you've got very limited staffing structures to manage this. You know, it's not many steps before you're down to a frontline support worker. So how research is designed is really, really key, and how it's delivered is really key, so that it, you know, adds capacity rather than reduces capacity in organisations. But when things are done in a really co-productive and sensitive way, and when things are grounded around the absolute realities of what care organisations are facing, it can be invaluable. So everyone who's supporting the work in social care, your work is so valuable. My advice would be, though, just spend time with care providers and understand their actual issues, and understand the backdrop that most organisations are facing presently.
Thanks, that's really helpful, John. I think the key take-home messages there are that if we want research to make a difference in the workplace, it has to involve people from the workplace right from the outset. And that's not just the professionals, it's also the organisations that employ those professionals and the managers, but it's also the people that are being cared for, the clients, the experts by experience, which we call public advisors here. And I think the key of what makes the ARC a real opportunity to grasp for those of us wanting to get that investment into research and implementation research around these difficult questions, particularly in social care, is we're ideally situated to be able to do that. We have the providers, we have the academics, we have the local authorities, we have fantastic public advisors, and our challenge is to use these opportunities at ArcFest and theme meetings and our research development networks, as we call them, to design high quality research, and to come to Caroline's team in the impact theme to design high quality implementation programs as well, and to research how those work. And Caroline, you might want to talk briefly about that.
Well, in relation to oral care? Well,
into anything, into just what we can offer in social care research.
Yeah, I mean, I think obviously you've seen some of the things that have been raised by different people at different places in organisations, and I think John's absolutely right. Understanding where everyone is coming from and trying to think how you can take those things into account is absolutely vital. And the implementation team are all about doing that, about talking to people who are involved with different roles in different places, whether it's patients, carers, staff, their managers, commissioners. So understanding everyone's perspective, because without those things, we design things that actually can never be implemented in practice. And research has been very guilty of doing that for a long time. So we test interventions which will never be adopted in the real world. And so that's the place of implementation science, is to absolutely understand how to design something that can be implemented. And that isn't an easy thing to do. And it takes picking everyone's brains to try and sort that out. So working collaboratively together is absolutely fundamental to that. So that's what our team is about, getting people to think about implementation from the get-go, because it's no use having it as an afterthought. You have to think about it right from the very start.
Thank you. And while Clarissa's thinking of any examples she can give of how that co-production has maybe changed fundamentally or significantly what was expected to be done, or how what's changed, if that's not to give you some thinking time. I was at this national meeting, as I said last week, and there's this traditional figure that's been given that every so often gets increased. It was 12 years, and it was 14 years, and it was 17 years that it was claimed it takes research to get into widespread practice in the NHS. But there's increasing evidence that that's not true anymore, and that actually the NHS is much better at getting research into practice more quickly. And what we were thinking of in the clerks, as were in ARCs as they are now, is maybe we've been partly responsible for that, because there's much more co-production now. And so we are coming up with interventions and with ideas from research that we already know what the implementation pathway is. And NIHR is very keen that we think of pathways to impact. They've got a policy on that, and it's a growing policy, and more things are coming up on their website. And soon it's going to be expected that when you apply for research grant money, that you already have a pathway to impact as part of that grant application. So it's definitely on the radar, and I think there is increasing evidence that that time lag is dropping. There is evidence now that sometimes it's taking less than a year to get research into widespread practice. So Clarissa, I gave you a bit of time. Have you got anything you'd like to add?
Well, I suppose just working with our large pool of unpaid carers and people with the condition as well, but also predominantly our charities, it's about really understanding where the need is. So we put together, for example, grant applications that really are addressing some of those gaps from their personal and professional experience. So not just what the literature highlights in terms of we need to go there next, but really combining that with their personal experiences. So for example, we're putting together an application now on a mental health intervention for unpaid carers, and we've consulted a large amount of unpaid carers for that. And we've shaped that intervention so much already just by talking to them about what would you like, how should it be done. So it's absolute key to have them involved in everything.
Yeah. I guess there's a parallel from one of the things I learned quite early as an incoming academic is traditionally lots of research, the outcome that was being tested was a laboratory measure or something like that. And patients, as they got more involved in research, said, that's all very well, but that's not what matters to me. What matters to me is my mobility or my pain or a symptom. So increasingly now, research develops an outcome measure that highlights the things that matter to the people with a condition rather than things that matter to the clinician. And that's what we're looking at, making a difference when we're putting in new treatments, or working in different ways.